Okay. Incisional surgery. Okay, so these are what we can basically split into penetrating, the more traditional ones, and the lower risk surgeries, which are called minimally invasive glaucoma surgeries or micro-invasive glaucoma surgeries, basically MIGS. Okay? And we'll go over how well MIGS go in a second, because you may have heard the tongue-in-cheek term MEGS, M-E-G-S, for minimally effective glaucoma surgery. And we'll see whether or not that's the case. Traditional penetrating surgeries, trabeculectomy and tubes. We all know about trabeculectomy. You create a fistula, so a shunt. Creates a bleb. The issues are bleb failure, lifetime risk of infection, and lifestyle limitation. You can't wear contact lenses in general. You can't go snorkeling or scuba diving, things like that. For our active baby boomer patients, this can be an issue. There's also other issues. You can have cystic blebs resulting in ocular surface disease. You can have scarred blebs, which is quite, it's in 5 years after trabeculectomy, you're more likely to have a cataract from the trabeculectomy than you are to have a working bleb. Okay? They've been around since 1968, and they've really not changed much in that time. So I think that we can all agree it's time to move on. And we're going to be talking about the potential methods by which we can move on. Traditional penetrating surgeries also include the glaucoma drainage devices. Essentially, there are two that are commonly used here in the U.S. The non-valved, which is the Barvelt, versus the valved, which is the Ahmed. And these have a number of issues along with that are shared, as well as somewhat unique from trabeculectomy. In the case of the trabeculectomy and glaucoma drainage devices, the main risks are pressure elevation and hypotony, so both extremes there. Okay? In the case of the glaucoma drainage devices, you put an implant on the surface of the eye underneath the conjunctiva. So not surprisingly, the implant can sometimes move. You can get into trouble with that. You can get an infection. If you get an infection on an implant, whether it's an implant in the eye or anywhere else, that's a big issue. You generally have to remove the implant. It's very hard to eliminate an infection on any non-biologic tissue. Scarring can cause double vision. Okay. And then there are other things. The implant itself, the tube, can erode. And with glaucoma drainage devices as well as trabeculectomy, if you end up with a sudden drop in pressure, you can end up with a suprachoroidal hemorrhage, so a bleed in the back of the eye that can lead to a total loss of vision, or at least put you at great risk of that. Okay, so essentially after incisional glaucoma surgery, that's the only time I will ever tell my patients that not only can they use a laxative or stool softener, but I want them to. Okay, because I want them to avoid any Valsalva maneuver, anything that could cause an increase in venous pressure, resulting in backflow into a hypotenuse eye. So given those risks, and given the fact that with glaucoma, we've got patients that generally can see, and we're trying to keep them from losing vision, I don't like offering surgical treatments that have a high risk of loss of vision.